Hello, and welcome to this episode of Data to Decisions, where over the next 30 minutes or so, you'll hear from two distinguished, innovative health organizations about their analytics journey and how they've benefited from using modern analytics. I'm your host, Tim Law, and today we're delighted to be joined by John Luzier with the Physician Alliance and Peter Rinaldi with St. Joseph's Health. Here's our agenda for today. We'll start with brief introductions. We'll talk a bit about the respective business challenges that made these organizations seek a new analytics approach, how they identified potential solutions, and what business outcomes they've achieved. We'll take the final couple minutes to peer into the future of analytics at St. Joseph's Health and the Physician Alliance. So let's meet the speakers. Peter, do you want to go first?
Sure, thanks Tim, and thanks for having me. My name is Peter Rinaldi. I'm the Director of Enterprise Analytics at St. Joseph's Health. There, I oversee our analytics infrastructure, including our data warehousing and data governance initiatives. And just a little bit about St. Joseph's Health. We are actually the 5th largest health network in New Jersey. We have 2 acute care hospitals, a children's hospital, and a health campus with urgent care, ambulatory care, and physician practices as well. Our flagship hospital is St. Joseph's University Medical Center, located in Paterson, New Jersey, which, of those who are familiar, it's a city that has issues with crime and poverty, and it's where the majority of our patients reside, which is why we have such a high Medicaid and charity care population. We're a unique hospital organization because we are a Catholic faith-based institution. We are founded and sponsored by the Sisters of Charity of St. Elizabeth. Our mission statement explicitly defines our commitment to the poor and underserved in our community. So it's important to note about St. Joseph's Health. Although financial performance is obviously very critical, no margins, no mission is what our finance team likes to remind everyone of. Our mission and our patient-centered focus is really our priority, and I would think a differentiator between us and many other hospital systems.
Wonderful, thank you for that. And John?
Hi, I'm John Luzier. I am the Director of Data Analytics for the Physician Alliance. We're a slightly different healthcare organization than most you've probably dealt with. We don't own physicians. We don't own hospitals. In fact, actually, we are owned by a group of physicians. We have about 2,400 physician members. About 1,800 of them are specialists, about 600 primary care, give or take. We have about 500,000 patients that are attributed to our primary care physicians in the Metro Detroit area. We're one of the largest physician organizations in the state. And we've had 10 straight years of getting a low-cost benchmark performer status, which helps us get some extra revenue to our primary care physicians. I apologize a little bit for the extra length that I'm going to have to go to, just because our business model is so much different than most healthcare organizations out there. I like to liken it back to an old religious saying that man proposes, God disposes. Well, here it's TPA proposes, the docs dispose. And if you know any docs and gods, not that much different, or at least in their minds sometimes. But really, our mission is to help the practices stay open and help their patients. I know there's an image out there that, once you're a doctor, you've got it made, you're going to be rich, you're going to make a lot of money, but that's just not true in most specialties. I mean, I know plastic surgery, there's some specialties where they do make a lot of money, but your primary care physician that you have down the street, your family care doctor, he's not making in millions. He's not raking in millions. I guarantee it. Most of the doctors get into this, and all of the doctors that I've ever worked with within this organization, they're here to help the patient. They're not here to make money. They're not here to, build another mansion or get another vacation house or anything like that. They're here to help the patients, because that's the only reason you would work 65, 70 hours a week, 15 hours of it working just to document in your EMR to stay compliant with the various regulations by CMS and insurance companies. for the amount of money that they make. Just as a quick example, in 2022, Blue Cross of Michigan paid out about $750 million for our patients. Only 6% of that actually went to the primary care physicians that these patients belonged to, which works out to about $114,000 per physician. And in Michigan, Blue Cross is pretty large. That's probably about half their patient population. So you can work that out. That's not a whole lot of money when you're talking about also having to pay your staff, keep your lights on, keep your computers running. So what we're here for is to help the doctors get more of the money that they should be getting from the insurance companies. Blue Cross Blue Shield is very good about having really nice quality incentive programs to keep their patients healthy. Things like, if the doctor makes sure that all the cancer screenings are kept up the way they're supposed to be, they get an extra amount of 5, 10, or 15% in their annual reimbursement from Blue Cross. We're in a number of shared risk-based contracts that basically incentivize good medicine and good quality, low-cost medicine, which helps both the patients, the doctors, and the insurance companies. That is the majority of our business, and anything that we can do to help these doctors help their patients, we're here for.
Well, thank you both so much for setting that important context. Truly important in terms of analytics. Just a quick word about Pyramid Analytics. The Pyramid Decision Intelligence Platform brings analytics to a wide range of business users, analysts, and analytic consumers. We enable governed self-service capabilities for anyone regardless of their skills, with embedded AI guidance for no-code interactive experiences, covering data prep, data science, and business analytics. We help organizations speed up insights, scale adoption, and simplify analytics. We're proud to note that we've just been named a visionary in the 2023 Gartner Magic Quadrant for Analytics and Business Intelligence Platforms. You can download the report from our website at pyramidanalytics.com or leave a note in chat, and we'll be happy to share the report with you. So let's jump into business challenges. I know both of your organizations face some unique challenges that require a thoughtful approach to analytics strategy. Peter, why don't you start?
Sure. So one of the biggest challenges I always said St. Joseph's Health, we historically had been a data-rich but information-poor organization. And data-rich in the sense that, like many other healthcare organizations, we are sitting on mountains of data. And that's because we have an electronic health record, which tracks pretty much everything that happens to our patients. We have millions of rows of financial claims information, and we have a whole host of external sources of data, whether it comes from different vendors or regulatory bodies. And the challenge is we spend so much time just getting our hands on this data and wrangling it in that we really didn't have enough time to focus on how to organize it so that the data was really centralized, governed, and easily accessible for the stakeholders who actually need it. We also lacked consistency on deployment of that data, as we had variable modes of distribution to go along with our variable sources of data. And another major challenge was our data procurement process for the business. It was very transactional in nature, in a sense that an internal customer would request a report for their very narrow specific need. And that was met with a report that was delivered to them to meet that minimum need. And there were some users who would essentially monopolize that process with the limited resources, and they would get what they need, but most, by and large, an organization were lacking for data and information. And it wasn't really just the challenge wasn't just getting the data out to people who needed it. It was also how to make sense of it so it could provide useful information that would transcend just summary level business intelligence reporting and move towards that decision intelligence model that many are moving towards. And that's why I use that term information poor. All those factors really cause us to be information poor. And it was essentially endemic within the organization, and it led to a culture where decision making was oftentimes based on anecdotal information, gut feels, or decisions were made just missing critical elements, organizational blind spots, if you will. It was frustrating because the data existed to help them, but what was really missing was an overarching strategy on how to deliver that information to them and translate it into actionable information. So those were really the major challenges that we faced.
Well, thank you. John, could you share your challenges with us?
Well, we had a little bit of a different journey to go on. Back in 2017, 2018, we were in discussions to get into one of these shared risk contracts, a fairly large one with Blue Cross of Michigan. And we knew that what we had in-house wasn't sufficient to really help drive the kind of cost savings, the quality improvements, everything that was going to be necessary to be successful in this contract. So we contracted with a third party to both host and develop a BI platform for us, and it worked well for us for a couple of years. And we ended up with some challenges with it. Number one was the cost. It was quite expensive to have this third party do this. Another one was it obviously wasn't very flexible. You know, without the ability to get in and do things ourselves, it was hard to make a change at a moment's notice. There had to be discussions, and then there would have to be a proposal and all of the things that you go through when you're working with a third-party vendor. And then the last one, and actually was the most important one, is the company that originally did the work for us decided to get out of that business and sold it to another company, which then sold it to another company. There was a large turnover in the personnel that we were working with. In fact, and this is both a true story and a joke, is by the time we were done, we were on our third data architect named Sarah in our time with this company. So at that point, we decided we needed to pull it in-house. It just wasn't going to meet our needs going forward. So some of the challenges to bringing it in-house were time and resources. There were basically two of us that could really spend the time working on it. Actually, at the time that we were discussing it, there was just me, but fortunately I did hire somebody in to help out. We had an existing code base of R and SQL scripts. I can't tell you how many SQL queries and R scripts I'd written in the 8 years I'd been here, but it was a lot, and I didn't want to have to throw those out, obviously. Obviously, we wanted to make sure we saved what was working from the old platform, in particular our panel management and our diagnostic coding applications, which were very, very important going forward for that blueprint contract. And then we really needed a lot more flexibility and extendability to the platform. When we found a lot of that when we went through a very long process of doing proof of concept with several different vendors, and just at the end of the day, Pyramid had the flexibility that I thought we needed more than anything.
Great, thank you, John. So let's talk a little bit more about that. We know that there are many dimensions to deciding on a platform to support diverse users, critical business needs, and often complex technology landscapes. I think sometimes this is even a greater challenge in health organizations because they do have a lot of complexity and are dealing with a lot of data and a lot of data systems. How did you go about identifying and selecting the right solution? Why don't we start with you, John?
But like I mentioned, I had developed a very long, probably too long, too involved, over analytical, but I'm an analyst, so what do you expect? Selection criteria for the software. Number one was obviously the ease of recreating the exact, or at least the functionally equivalent of the existing application. At the end of the day, we ended up with about 6 or 7 months to actually implement this and get this out. So we knew that if we had to spend 4 or 5 months just learning the tool, it wasn't going to work for us. It might have been, it's possible there was a fantastic tool out there that, in 10 years from now, it would have been worth it, but we didn't have 10 years to get this done. Number two, we needed something that could handle all of our needs instead of just displaying the data or just doing the visualizations and the dashboards. We needed something that would also help us consume, ingest the data, clean it, help us get better at some of our exploratory data analysis, especially a lot of our EDA gets done with non-analytic users, such as some of the doctors that advise us. So we had to have something that was able to create that easily without, me having to rewrite a new SQL query every time we had a meeting, which is what we were doing before this. And like I said, just a cleaner way to take care of all of this all in one shot instead of having to go out for 5 or 6 tools or building a shiny dashboard in R, which is a great tool and I love it, but there's no way I had time to create shiny dashboards for everything that we did. And then, obviously we had to be able to match what we had. And thankfully we were able to find all of that in Pyramid.
Wonderful. Peter, how about your situation?
Well, first and foremost, like I spoke about earlier, we needed broader reporting to our organization, but just delivered in a more streamlined and efficient manner. That was essentially the foundational need of the tool we were looking for, but it also encompassed some very specific requirements at St. Joseph's. It would have to be flexible enough to connect to data from our variable sources and different technologies, as well as have the ability to prepare and move data in and out of our on-prem data warehouse. So the ability to write to our SQL Server environment was key. And by and large, flexibility was just a major key consideration. And similar to what John was saying, although we needed to produce more, we had to ensure that our current level of reporting that stakeholders found sufficient was maintained as well. We didn't want to just throw it all away. But here that entailed the fact that many people needed their Excel-based reports as well as PowerPoints or PDFs. Their preferences were that these were emailed to them on a daily or weekly cadence, and they would just pull them down whenever they need. So our reports library tool, while somewhat archaic, they did find sufficient. And I'm sorry, my automatic light just went off. So it was important that the tool not only had the ability to produce advanced visualizations and dashboards, but have the seamless ability to produce spreadsheets, PDFs, PowerPoints, and do the auto scheduling distribution of them as well through a web-based platform. And we wanted the transitioning from our legacy platform to be really relatively seamless and painless as possible. So that was a major key consideration. And lastly, we were really searching for a tool that could, I would say, leverage and extract the most value out of our relatively limited resources. As I discussed earlier, we have low income, high Medicaid payer population here. So we're not an organization with large margins to work with. We don't really have a surplus of analytic resources, nor are we going to win any bidding wars against other big names in healthcare. So we don't really have analytic specialization, is what I said. We don't have a host of data architects and data engineers on board. So we need a tool that could help our analysts model data, move data between systems, and perform ETL-like processes without really that requisite technological expertise that would usually entail. And we don't have any data scientists on board as well. So we needed to have a tool that would empower our analysts to have the capacity to produce outputs that a data scientist would, utilizing existing AI or ML algorithms. But again, without that advanced technical and coding skills that it would usually require. So really, we were looking for a tool that would not just simply help with the reporting and the visualization, but a tool in itself would actually help us move up the analytics maturity ladder.
Wonderful. Thank you both for that. Let's move on to business benefits and outcomes. So after taking these thoughtful approaches to uh, revamping both your analytics strategy and your platforms, what business benefits and outcomes did you realize? Why don't we start with you, Peter?
Sure. Well, there was a few dashboards we were able to get up and running pretty quickly, which were successes. The first one was our COVID dashboard. And when COVID initially hit, Paterson, New Jersey, 20 miles outside of New York City, we were in the epicenter of that first wave. So an emergency operational command center was quickly set up to manage operations. But in parallel, we utilized Pyramid to serve as basically a virtual command center for our COVID common understanding. Knowing the number of cases we had in-house, where those patients were, incoming lab results, this was all critical information that we needed timely and accurately. And the status quo of different people generating reports, distributing those centrally with disparate timeframes, that was basically too error prone and too slow in such a high stakes environment. So our dashboard functioned as a centralized repository of all COVID related data that was needed internally. But it also served the dual purpose of being the mechanism with which our daily reporting to regulatory agencies was generated out of. There was a lot of state and federal reporting requirements, which were put into place with very little lead time on development. So the ability to ramp this up so quickly was critical, as obviously at this time it was not the type of development process we could wait around months for, considering it was COVID. Another major dashboard we created was our executive level dashboards, which I always consider our first win on the effort of improving our strategic decision making. So really moving away from that business intelligence to decision intelligence. The dashboards, they were cross-functional. They encompassed pretty much everything: our finance, quality, clinical outcomes, human resources, operational metrics. And again, historically, these all would have been collected in silos, and the information would have been delivered to others and executives in like standing monthly meetings. But now we had the ability to see all the other departments' information more timely and with greater depth and detail. And the feedback was this cultivated greater collaboration, sharing of ideas, and it proved instrumental in some of the key decision-making that occurred in the organization. And one other broad-based benefit, not a specific dashboard deliverable or analytics deliverable, was really, again, that efficiency that was had because of the streamlining of reporting. Here, again, we were very Excel-based, very manual data collection. There were analysts that spent, I would say, an inordinate amount of time just collecting, compiling, and moving data around. And here, these analysts generally had other operational duties within their departments, like basically understanding their department workflows and processes. So really, the streamlined reporting removed a lot of the busy work and tedium of what they were doing and allowed them to reallocate their time to work on process improvements, and at the same time, not just collecting data, but really diving into it and analyzing it. So those were some of the major benefits we reaped with our pyramid implementation.
Thank you, Peter. And John?
Well, I mean, bottom line is in 6 months, 2 people were able to duplicate a fairly large dashboard application serving 3 different large areas in our company. We're able to get that up and running in 6 months, and that saved us $350,000 a year over the third-party solution. Which obviously, you know, it's everybody's bottom line here. That's a nice big win for us to start with. Beyond that, more importantly, is we gained the ability to quickly pivot when, you know, changing conditions came down the road, when some of the revenue models we thought we were relying on changed suddenly on us. In fact, actually about 4 months into the project, we had to switch directions and add some things that we had never even scoped out as part of the project. We were able to bring in some forecasting for internal revenue that we've never had before. Being able to actually predict what our future revenue was going to be from Blue Cross, which obviously is a big help when you're trying to decide what to spend on and where to look at in any business. And it was something that was kind of lacking before, and we didn't really have the ability to do that. It's also helped us develop I guess what I'd call a holistic view of a practice, instead of just looking at a practice and seeing, oh, they cost more than the practice down the street per patient. We can dig in more and maybe see, oh, well, okay, maybe this practice, they're in a socioeconomic area that they have more difficulty. There aren't any urgent cares in that area. So we need to look at, possibly helping them out with partnerships that way, so there's less emergency department usage. Maybe because of possibly their EMR or one of the systems that they rely on, they're not getting proper what's the word I'm looking for? Risk coding done, which is kind of a complicated concept, but basically it is how we get judged on everything is a acronym RAPMPM, which is risk adjusted per member per month spending. Basically, if two patients both cost $100 last year, but patient A was, say, an average risk level, but patient B was, due to maybe diabetes, heart failure, a number of other conditions, double the risk level. When we're getting, quote unquote, scored for those cost numbers, that second patient with the high risk level would look like they only cost $50 versus $100. And that ends up being a very important concept when you're trying to save those costs and hopefully bring more benefits to our doctors through that. But finding the areas that can be cut without hurting patient care can be difficult. They're not the same in every practice. One practice we may find that it's if everything was properly coded for these patients, they would look a lot better, and they don't really need to change anything about treatment. One of the things our CEO likes to say is that for 30 years he's been looking for the quote unquote bad doctor, as far as somebody that spends way too much, and in 30 years he hasn't found one, because generally the doctors are doing the best that they can with the tools that they have, and they're treating the patients to the best of their ability. So sometimes there are alternatives that they don't know about, and we've been able to use Pyramid to come up with reporting and dashboards and analytics that can give the doctors alternatives to higher cost care. That many times it's actually an improvement to the patient. One of our biggest programs is our panel managers, which is a group of RNs that will follow our highest risk patients, and we'll call them within 24 to 48 hours of a discharge from the hospital to make sure that they have an appointment scheduled with their primary care doctor within a few days. Make sure that they understand their discharge instructions, they have all their meds, everything that they need, because these things have shown, particularly the transition of care visit at a primary care physician, to be the number one reducer of readmissions to the hospital. And for everybody involved in healthcare, a readmission is the worst thing that can happen for the patient, for the insurance company, for the doctor, even for the hospital, because that looks bad on a hospital's quality ratings with the government if there's a lot of readmissions. So everything that we can do to help lower those is a good thing. And our panel management program, both before and now with Pyramid, has reduced our readmission rate for this group of patients from about 15% to less than 5%, which is a huge savings and also a phenomenal improvement in care. I think I went on enough for that.
Thank you for that. I did promise we would spend a little bit of time at the end here talking about the future of analytics at both of your organizations. So why don't we do that? Peter, if you want to start.
Sure. So what we're looking at is like at St. Joseph's, we currently have a decentralized analyst model, and for the most part, that model will remain. But we're really looking to strengthen it with more governed oversight of those analysts, so that we can provide more standardized deliverables. So we're really looking to take them to the next step and ramp them up on that self-service model of producing dashboards on their own. And not just a reporting self-service model, we're really looking to deploy the ability to derive insights as well on their own. So training them and ramping them up on the automated insights functionality that Pyramid offers, the integrated predictive analytics pieces as well. Like I spoke about earlier, we don't have data scientists, but that no longer precludes us from using the tools of a data scientist, even though we have analysts who may not necessarily be able to code in Python or R. And another thing we're looking to do now that we have the capacity to do so is consolidate our vendor-based reporting. We have a lot of vendors, which they all have their own native reporting modules, but we've found these are pretty static and inflexible. To create custom reports out of them, it's clunky. We have to go through the vendor to make adjustments. And so it's slow to delivery, and oftentimes there's a cost associated with it. So we're really looking to ingest most of our vendors' raw data wherever we can and produce our own in-house dashboards. And the big benefit of this is, again, this provides a ton more flexibility what we can do with the data. We can hit a larger audience with that centralized distribution capabilities. Like right now, the current model requires that siloed analyst to log into that very specific tool, download and distribute a report through email. So all the administration is done by that analyst locally. So with the data centrally housed, that administration, including very importantly, the security and user access administration, can be centralized as well. So we have now, again, more control and oversight. So really, briefly, the future really is just iterating off some of our modest successes to date, and really leveraging the full suite of tools at our disposal that Pyramid offers to help drive more insights, mature more so analytically, and really help us achieve our mission.
Great. And John?
Honestly, I feel like we've only scratched the surface of what we can do at this point. We are extraordinarily happy with what we have done, but I see this vista out in front of us, and sometimes my reach definitely exceeds my grasp on this stuff, but we definitely want to get into much more predictive analytics. Everything from based off a patient population, let's predict whether a particular practice is going to be able to hit their quality goals for the year and thus get a extra reimbursement from Blue Cross. Predictions and studies to find out which practices are the best fit for these shared risk. And as more and more medical insurance companies do, they're going into full risk, where every dollar extra that you spend, you owe them a dollar, or vice versa, which always confuses me because I thought insurance companies were supposed to take all the risk, but that's another issue. We're also in the process of building out a few narrative reports for our practices, where we can both show them the data, but also explain it at the same time. As you can probably guess, doctors are very busy and they don't want to have to sit through 3 pages of explanation and then a page of stats to figure out what's going on in their practice. So if we can mix all of that together, maybe explain why a certain figure, for example, having your hip replacements done at XYZ hospital is not the best idea because maybe that hospital has a higher readmission rate and it costs more per occurrence than the hospital down the street. We can show that to you, and then also show what kind of, if you had done that last year, what the what the effect would have been on your overall financial picture. You know, would it have resulted in more money coming in, or, you know, and better patient care, which is obviously what we're always looking for. We're definitely always looking for those win-wins. We also want to get more into self-service analytics for our practices, so that the doctors can come in and, you know, start looking at this data on their own instead of having to have it served up to them. You know, I dabble in data science, so I would like to get back into doing more data science, and I can see a pathway to that through Pyramid. In fact, actually, I've been able to work in some of my pre-existing scripts where I had done some data science work, and was able to work that into an actual data flow and visualization, which, you know, that was a huge bonus for me. So yeah, I guess just more of the same, and I can see that the future is very bright right now. But I see more on my plate than I can possibly do, but I like having options.
Excellent. Well, thank you. That concludes our presentation. Many thanks to all of you who joined us, and a special thanks to John and Peter once again for sharing their analytics journey with us. If you'd like more information on the Pyramid platform, head over to our website at pyramidanalytics.com, where you can read use cases and request a demo. Just click on the button there, and we'll be happy to set up a personalized demo for you. Thanks again for joining us.